This is them, 26 years old, like 15 months ago, came in the complex of Harvard and working for 5 years and studying economics. Oh, that's good. After it was turned on, recent problems to like I think so. Actually, I wanted to find
examination. So 26 years old, primary with fevers, vomiting, spotting fever with clinical examination finding of black rash on the abdomen with travel short and then. So first differential, first new malaria, second dengue, scrub, and fourth entry. So
where did you think this problem started? Started in Tanzania or in India?
Tanzania.
You feel it's from Tanzania. Okay, but the problems you mentioned, some of them are not present in Tanzania. So can you just dwell on that a little bit? So why do you think malaria, dengue, scrub, or enteric is from Tanzania or from India? And just discuss the incubation periods. What makes you think that it happened in Tanzania?
Technologically,
You were there 20 days. You want to maybe as a good start, you just tell us how long did she stay, what was she doing there? All those become incredibly important. Where was she staying in Tanzania? That history is critical for you to say that it started in Tanzania. Okay, can you tell us that?
Details.
You're not sure. Okay, so if those details are not available for us, then maybe you go through each of them and say that they have African parents because it's in so many beaches. No, what do you think about Malaysia? And we've been arguing studying after 20 days on the so what sort of malaria, sort of words like that, I will make since presence after 20 days. Okay, so now it becomes very that working on some analysis, or some analysis, looking like the pregnancy, things like that. So, what do you think? So, should we look in the study as well? Yeah, only 1700 dollars. Sorry, yeah, so usually they would draw a line. We were considering 20 days for the start of history is true. That would sort of negate many of those things. As you rightly said, you could have virus, malaria coming up and creating problems like that. So those are the things you would feel when somebody sort of comes from a country and
so she had gone 6 months ago, we did a husband, in terms of 7 years. 6 months ago there, and second trimester she has come back. Consular fever was 4 days after she reached India.
Okay. Yeah, so that gives us sort of context. So it's obvious that, but we didn't with that, we just come over there and maybe pregnancy part of it. And then, yeah. So, function the model, really national amount, where we have also good function of 1990s. But also taken up with other elements that was illegal. Even parasites was positive physical link and elements. Some that's the levels of percent. So,
We should dwell on the malaria parasite report. You need to tell us what your interpretation of all those things is.
So, she came with one is history of spotting TB and parasitic index of 2%. She comes in the severe malaria category. Second, her liver enzymes, coagulation parameters.
I just want you to interpret the malarial parasites report. Maybe you can take us through the LFT later.
Yes.
Just go to each level. So what sort of test is that? MP positive.
Smear.
What's there?
So, Buffy coat, quantitative Buffy coat.
So you're talking two different tests.
Yes.
The smear tests are very different from QBC, what you just mentioned. Okay, so maybe this are QBC,
Yes.
because are they done in CMC?
This one is in CMC.
Okay, so then these are QBC reports very likely. They might have done smears also after that. So tell us, what do ring forms mean to you?
The infected, the schizons.
Usually ring forms
Ring
mean an active
active
infection, isn't it? So you can correlate this fever history plus the active malaria. Now, what do the parasitic density and parasitic index mean? How do you interpret those values?
So, it can classify the severity of the malaria. More than 2%, yes, severe malaria.
But I think more than parasitic index, the reason one is parasitic density.
Yes.
So how to make sense out of that density?
The viral load of the malaria.
Parasitic load, you mean? How do you quantify it? Those are things you should have looked at before you come and present in a clinical meeting. If you're presenting some reports, you should say what do they mean. None of us see malaria common. Yes, and it's a good opportunity for you to look out and see what do these things mean. Would you go and look them up and see how to interpret these things? What?
She was started on injection artesunate according to her weight, 0, 12, and 24 hours, followed by artemether lumefantrine for 3 days. Regular screening was done. She did not develop any features of any complicated malaria. So she had come after 6 days with a drop in. She presented with fever and acute onset dyspnea. The clinical examination of pallor and elevated JVP, and there was a significant drop in HP from 7.59 to 3.2. So now, any differentials you would like to consider in this? So this is our CBC report, which is showing only HB of 3.5. Platelet count and other cell lines are normal with only HB. The urinalysis of normal urinalysis. So the differentials which can be considered is one is black water fever, which comes with presentation of hemoglobinuria with intravascular hemolysis, features of intravascular hemolysis. Since she had got an anti-malarial artesunate, so drug-induced hemolysis will be our second differential. Third,
autoimmune hemolytic anemia. Lower down the list, PNH and G6PD, however, she didn't had any features of any thrombosis or thrombotic event, or there was no pancytopenia, other cell lines were normal. And fourth differential, health syndrome, which actually comes in second or third trimester. So coming back to the hemolytic anemia, first evidence of hemolysis, there was anemia, reticulocytosis.
Let's come back. This thing really, what are the most likely etiologies? It's easy to anchor things,
Yes.
but you should know this is what I'm most likely dealing with.
Drug-induced hemolysis is one. The first which I would be thinking.
I presume, I think you're dealing with either hemolytic anemia or very likely you're doing something drug-induced. That's your prime thought. So black water fever, if at all you want to keep, should come really down because she traditionally doesn't fit into a severe malaria presentation.
Yes.
So, yeah, so that's something you order them according to your thought process. Yeah.
So she had anemia, reticulocytosis, indirect hyperbilirubinemia, and elevated LDH levels. Haptoglobin was not done, but if it was done, it would have been low. In case of so reticulocyte count was 7.96, LFT showed a mixed hyperbilirubinemia. So hemolytic anemia, there was a possibility of G6PD as well, but since she was in a state of reticulocytosis and acute hemolytic state, so G6PD will show a false negative likely case. Other peripheral smear was done, which didn't show any sickle cells, or there was CBC was not cytopenic thalassemia pattern. So DCT was done, which was negative, so which negates the immune mediated, and finally we come with a pattern of a non-immune mediated, in which the two possibilities, one was infections and second is drugs. So malarial parasites, repeat malarial parasites was sent at this presentation, which was negative, which didn't show any viable parasites. Renal functions was normal, and there was a possibility of microangiopathic hemolytic anemia. Schistocytes was nil. Other coagulation parameters, one was normal. Fibrinogen was 676, mildly elevated. So the thing remains is a drug induced. So we looked up, and today will be presented. I will be presenting on post-artesunate delayed hemolysis. So this hemolysis usually occurs typically after 7 to 30 days after the initiation of artesunate-based therapy, and usually it is more common in patients who are coming from endemic areas and non-immune travelers. And it has been found to have a prevalence of as high as 50%, and more than half of the affected cases require blood transfusion. However, there are no literature having any fatal outcome being seen, and they present as features of hemolysis with anemia, jaundice, and dark urine. So they will have the lab investigation will have a pattern of hemolysis with LDH high reticulocyte counts with indirect hyperbilirubinemia and urinalysis having hemoglobinuria. So the pathophysiology is
Just come back. Maybe you should go with all of them so that it is clear.
yes. So there will be elevated LDH concentration. There will be reticulocytosis and increased hemolysis of the RBCs, causing conjugated bilirubin. And if there is an intravascular hemolysis, there will be blood in urine. So pathophysiology, artesunate is a endoperoxide moiety, so it causes free radicals causing killing of the parasite, following which the dead parasites in the RBCs, they travel to the spleen where it undergoes some phenomenon called pitting, in which the RBCs containing these plasmodium are getting cleaned up, and the post pitting there will be RBCs which are left, which are called clean RBCs, which have shortened lifespan, with the lifespan which will be around like 7 to 21 days. So following the artesunate therapy, after 7 days, there will be increased lysis of those RBCs, translating into a hemolytic picture. So this is a study which compared quinine and artesunate with the outcome being a proportion of delayed hemolysis, which showed a significant drop in mean HB at 3 weeks and increased LDH at 3 weeks, and the duration of follow-up was 4 weeks. So they took the patients of severe malaria and they followed it up weekly once, and they found out this drop in HP at around 3 weeks specifically. So the timing of G6PD actually plays an important role. So in this case, G6PD at that point of instant would have come as false negative because the severely reduced G6PD would have been hemolyzed at that time. So ideally, it's done after 3 months of the hemolytic phase. And G6PD hemolysis usually occurs 24 to 72 hours after exposure, which can be differentiated from the artesunate-based hemolysis. So CBC should be done at an interval of 7, 14, and 21 and 28 days after the artesunate administration. And the management is just a symptomatic management with blood transfusion. So our patient, she was transfused 3 points of blood and she was symptomatically managed, and her HB increased to 9 grams and she was asymptomatic time of discharge. So learning points is a post-artesunate delayed hemolysis, one I want to highlight.
Are there any questions? Comments?